Speaking of arthritis, hands up or a thumbs up, who has osteoarthritis, if you'd like to participate.
Yes.
Yes. Okay. Oh, 1, 2, 3, 4, 5, 6, 7, 8, 9. Great. Okay. Not great that you've got osteoarthritis, but thank you for joining in. And those who have rheumatoid arthritis. Anybody who has a rheumatoid arthritis with us tonight? So that either means that, okay, yep, there's a few there. 1, 2, 3, 4, 5, maybe 6. Who has any other rheumatic autoimmune condition, like ankylosing spondylitis, like psoriatic arthritis? If that's you and you don't mind sharing, would you mind just popping that in the chat box for me? That'd be really great, just so I know kind of what we're looking at here. Okay, fantastic. All right. All right, thank you, everybody. I can see those coming up in the chat box now. It's good to know who I'm speaking to, so what conditions you have. And that way I can sort of tailor it a little bit. But when it comes to pain management in the context of its education, it's pretty much the same across the board, with slight differences between the different types of arthritis. But without further ado, I think we'll get into it, don't you? We should be going for about an hour, so I'll make sure that we finish at 8:30, and hopefully there's a little bit of Q&A time at the end as well. I'm just going to share my screen and I'll get the PowerPoint up and ready. Okay. Fantastic. So we should all see the PowerPoint presentation there. So my name isn't Arthritis New South Wales, as my tagline says on the video. My name is Kat Keane. I'm the health educator at Arthritis New South Wales. And apologies if you've heard the spiel before, but my background is in exercise science, education, and with an honours in psychology. I often put together the content and often present. You may also have seen Andrew Cairns. He is an exercise physiologist and he is the health services manager. Before we get into the session proper, it's always important to address the disclaimer being that the presentation contains general information and advice. While every effort has been made to ensure that the information is accurate and reliable, it's not a substitute for the individual treatment advice of your doctor or healthcare professional. And we encourage you always to take whatever you find here tonight. If it challenges the things that you've been told or how you were treated, that's kind of a good thing. If it sometimes challenges those advices or therapies, but take them to your doctor, take them to your healthcare practitioner, and have a really good and robust conversation about it. Okay, so as I alluded to earlier on, the outline of tonight's session is all about pain. What is pain? So just speaking of pain, outside of the context of arthritis, I'm going to be looking at acute pain and chronic persistent pain and the differences between the two of them. Then we'll have a little look at how pain works, which is really important. So you can understand exactly what is happening. Then after that, we will then
try and reduce it.
May I just ask everybody to put themselves on mute, just so there's no added and extra noise in the background. Thank you. So yes, so then we'll be looking at arthritis and pain. So I'll be putting pain in the context of arthritis, and then
oh my stars,
I will just mute everybody if I can. I'll say again, if you guys don't mind, if you haven't already, Muting yourselves, please.
That's actually in that book.
Also on that last bit of housekeeping, if you have a question tonight, you may find that I'll answer it as the session unfolds. But what I'll get you to do, if you don't mind, so that question, you don't forget that question, please put it in the chat box, and I'll come back to those at the end of the session, hopefully when there's time, and I will answer them as best I can for you. Excuse me. Okay, so let's start with, what is pain? Let's have a look at the difference between acute pain and chronic or persistent pain. So acute pain is short-term pain and tends to be more associated with tissue damage or possible tissue damage to your body. For example, you might sprain your ankle. It's likely that you feel pain in the associated area, the direct area. There might be some bruising and some swelling that causes pain as well. This is acute pain due to a sudden injury. Usually it'll settle down as your body heals because the affected part no longer needs protecting. Healing usually takes less than 3 months, even for quite severe injuries. And that's give or take. Different tissues in the body, like muscle tissue, tendon tissue, ligament tissue, they all take slightly different times to heal. Bone tissue, skin, they all take different durations in which to heal. But likely the tissue, the damage that has occurred will have healed within the 3 months. Or on the other side of the coin, you've got chronic or persistent pain. And this is pain that lasts longer than acute pain, and it is often not indicated as ongoing damage, even though it may feel like it. In the past, we assumed that it was because we had not healed after an injury, like the tissue hadn't healed. But for most people, we know that this is unlikely. Instead, the pain is less to do with the injury itself, so in our bodies, and more to do with changes in our nervous system. It's like the volume knob or dial on your pain system has been turned up and it's been left turned up, like a radio stuck on loud. So you've turned your radio on to listen to your whatever it is, your show, music, and you turned it up really loud because at a point in time you really needed to hear it. There was some really important information coming from that radio. But unfortunately, after you've heard that really important information, you can't, that dial is broken and you can't turn it back down. And it's actually no longer helpful that dial is turned up and it's really loud. So this is what we're going to unpack as we move through the presentation tonight. But first, let's briefly look at how pain works. It might seem strange, but pain is actually a really good thing. Particularly that may be hard to hear coming from some people who experience pain every single day, but it's actually a good thing. It's an adaptive quality. When you first injure yourself, acute pain can help you change what you're doing so you can avoid further damage. Without acute pain, a person might keep running on an injured ankle, for example, or keep opening a healing wound. When we injure ourselves, for example, like this poor guy stubbing his toe, our nerves carry lots of information to our brain to make us take notice of this incident. In our body, there are millions of nerves that constantly interact with each other. And it's not just a one-way street. So it's not just when this guy stubbed his toe, messages are going up to the brain. Messages are coming also back down from the brain to the toe. So there's constant chatter. It's a two-way street. There's a lot of buzz in every direction. So what about the brain? Well, the brain is what actually produces pain, or it interprets the incident and it produces pain. So that person's toe and that tissue and the nervous system down in that toe doesn't feel pain. It's the messages that are interpreted by the brain, and the brain produces pain, the experience of pain for us. The brain is really important when it comes to understanding pain, and it may surprise you to learn that all pain, no matter where or how it is felt, is produced by the brain. When you injure yourself, the nerves in your body can only tell your brain that something has happened, something's wrong. This is dangerous, or we are in danger, or there's potential danger coming. It is your brain and not your toe, for example, this guy, that interprets this and says to you, hey, this hurts. But before your brain tells you that you're in pain, you must combine a whole heap of information and then try to make a sensible interpretation out of it all. Your nerves just say to your brain, danger, danger, danger. Something is happening to your toe or to your body. And your brain then weighs up many aspects of your immediate environment, as well as other life factors, such as what you do for your job, your personal or your cultural beliefs, whether you've injured your toe in the past, and what you're planning to do in the future. All of these things actually make a difference to whether we feel pain and then to the severity of pain that we feel. Only after sorting through all of this will your brain tell you whether your toe hurts or not. It does this incredibly quickly. It's in a blink of an eye or less, and it's done well before we're even aware of it. When a person first hurts themselves, it's normal to experience soreness, both near the actual site of the injury and also in the surrounding areas as well. So for example, you could be stubbing your toe like this poor man, and not only will he feel pain in the toe, the tip of the toe, but in the joint of the toe, and even potentially up his foot as well. But that doesn't necessarily mean that there's tissue damage in the foot, but he's experienced pain in and around that general area. In this scenario, the volume around that area is temporarily turned up. The nerves are turned up. The volume of that radio is turned up. So all the messages can be interpreted, or should I say, all the messages can be received and sent to the brain. This is absolutely normal and actually really helpful at first. This increased pain can remind us to slow down. Maybe we need to put some shoes on. Maybe we need to rest our foot. Maybe we need to ice our foot if that's our preferred measure of treatment. So it's actually quite helpful. Usually this pain settles down quite rapidly as we get back to our normal habits and activities, and of course, if and when that tissue does heal. In some situations, however, pain can hang around for longer than it's helpful. And remember, this is what we call persistent pain, pain that hangs around longer than necessary. And it's often related to extra sensitivity. So that buzz, that chatter, that buzz up and down the nervous system, amongst the nervous system, starts to set up what we call a self-reinforcing feedback loop. So the dial at our toe remains turned up. That volume dial remains turned up. And if we're receiving a lot of feedback from stage 1, which is the toe, as you can see, the dial in the spinal cord might also be turned up. So it's receiving a lot of information. Instead of sifting through it and only sending up what's necessary, perhaps it sends up more than what's necessary. And the dial here in the brain is also turned up. It's receiving lots and lots of messages, and it may be now having trouble sorting through the truth from not the truth. Not happening, what's happening. It's not sure, it can't tell. So perhaps we're feeling and experiencing pain because the body isn't sure whether we're in pain or in danger or not. So here's a question to you now after hearing that. I'm going to put up a poll so we can all participate. It's a true or false. Pain always equals tissue damage. I'm going to launch the poll. You'll see it come up on your screen and you can select true or false. Pain always equals tissue damage. Some people have been listening. Excellent, excellent. I'll just give it another 5 seconds. Anybody else would like to participate? Great. I'll end the poll and it's all anonymous. We can't see who answered what. And I'll share those results with you so you can see what the group thinks tonight. False. Pain always equals tissue damage. Well, we have our listening ears on tonight. You would be correct. The answer is false. All right, then let's talk about that in a little more detail. So why pain remains? The volume dial remains turned up. It often feels like persistent pain is due to ongoing or recurrent damage to your body. However, pain that remains after approximately 3 months often has more to do with changes in your nervous system. The original injury would likely have healed as much as it can, and although you may still be getting some signals from stiff joints or poor muscle control, the biggest problem is often the increased volume dial. That is, your nervous system becomes more sensitive, hypervigilant, and it wants to protect at all costs. So it sends up as much information to the brain as possible. While persistent pain may feel a lot like acute pain, it tends to act a little differently. So what happens is your nervous system responds to normal messages, such as touch, such as cold, heat, and movement, as if they were dangerous. So the volume dial stays turned up long after the injury has healed. Even a little bit of information input. So movement being a big one. Some people get it so bad that even clothes, something resting on their skin like clothes, which you probably don't even think of. Some people have chronic pain so bad that wearing clothes actually causes them significant pain. So something that might not hurt actually starts to hurt, or something that may have just hurt a little bit starts to hurt a whole lot more. So we just our systems in the periphery, so the nervous system down in our limbs and our spinal cord and our brain, being our central nervous system, all becomes hypersensitive. So these are all signs that the problem is changing from one of physical injury to that of a turned up, sensitized nervous system. When the nervous system is sensitized, it is common to experience pain with everyday movements, such as walking, bending, or twisting. In some cases, just even thinking about a particular movement or activity can trigger pain. Why does this happen, and what actually causes these changes? Well, when a person repeats a particular movement or activity on a regular basis, like bending over, perhaps when you go to sit down, when you go to the loo, when you go to put your shoes and socks on. So when a person repeats these movements or activities on a regular basis, the brain creates a pattern of nerve connections, okay? We do A, B, C, and D, and that equals bending over. It's a pattern of nerves that it creates. So it's like your brain has joined the dots between, say, the normal sensations coming from your back You may not even really be aware of them until you start having a problem with it. So your brain has joined the dots between normal sensations in your back when you're doing the movement, which is bending, the movement of bending itself, the potential memory of injury, and the experience of pain. So it's starting to join all these dots. And this is an unhelpful pattern. And it can become sensitized or turned up. Once sensitized, just preparing to do that particular movement, like bending over to retie your shoelace, may be enough to cause the pattern to kick in and for you to feel pain. The body has healed as much as it's going to, but the movement itself still hurts. So I've treated many a client in this predicament, mainly with non-specific low back pain, maybe not necessarily having arthritis in their spine, but perhaps having hurt their back a long time ago, and having done X-rays, CTs, MRIs with no actual structural changes or injuries, but yet they are in extreme pain when they go to move. So I've treated many clients who are like this, and this is what they would be experiencing, a chronic or persistent pain, that the movement itself has become painful, not actually the tissue itself. The tissue is healed and fine. So it's very interesting, and it's extremely complex. Here's another question for you. Can emotion or stress cause or influence the pain experience? Once again, I'm going to throw a poll up there, and I want the other poll. Where is the other poll? One moment. Oh, stop sharing. Okay. Here we go. Can emotional stress cause or influence our pain experience? So give that a go. Yes, no, maybe, I'm not sure. If you've just come into the session, the webinar tonight, I'm asking a question. See if you can jump in. There should be a poll up on your screen. The question being, can emotional stress cause or influence our pain experience? Okay, I'm going to end the poll there. Let's have a little look. Share these results. And majority of people who answered said yes. Yes, it can. And you would be correct. Excuse me. So let's talk about this in a little bit more detail. So what we need to do then is consider the biopsychosocial model when it comes to pain. More specifically, persistent or chronic pain. Every system that keeps our body running can get involved in producing and responding to pain. The way a person experiences pain is influenced by a lot of factors, as you can see here on the slide. We are social, spiritual, physical, and mental beings. Persistent pain is a whole of life problem. So effective management needs to be of a whole of life approach. Put simply, the way we experience pain is highly influenced by our overall well-being. Most of us can recognize stressful or emotional situations that have affected our pain. It might have been tiredness following too little sleep. It could have been an argument with our spouse or kids, a rough day at work, anxiety about paying overdue bills, or grief of the death of a friend. Our thoughts, our beliefs, and environment can also make us susceptible to a turned up nervous system and therefore more prone to persistent pain or developing persistent pain. Although we know clearly that pain is not a conscious decision, we don't consciously want to be in pain, we also know that our conscious decisions and actions can make a huge impact on our pain. Research points to a number of factors that influence persistent pain, and these include how scared, stressed, or worried a person is at the time of injury, what the injury means to that person, what impact may it have on that person, will they be able to provide for their family, what they believe, their beliefs, culture, religion all comes into this. How long a person avoids their normal activities, that might also, come under perhaps how worried or scared they are or fearful they are of movement or an injury or pain happening again. And there's always some sort of genetic or hereditary sort of predisposition being, a person's family history. Once again, many of the clients that I have treated over the past, those with low back pain, but also those with conditions like arthritis, can often find themselves in this heightened state. And they have the disease condition itself, whether that be osteoarthritis, rheumatoid arthritis, and that inhibits them from engaging in their normal activities of daily living. And when there's a barrier there, that gets us frustrated. And we interpret this barrier in many different ways. We might get frustrated. We might feel down. Our mood is low. We may feel anxious. So I've treated many a client who is in that situation, and it's never just treating the pre-existing injury, and there may not even be anything there in terms of tissue to treat. More so, I'm helping somebody understand the situation that they're in and helping them move forward from that situation. So in conclusion of this slide, personal beliefs and environmental factors can make a huge difference on how we experience pain and how likely it is that pain will persist. Interestingly, the natural chemicals that occur in our brain, that are released in our brain, connected with tiredness, stress, anxiety, or depression are very similar to the chemicals used to communicate danger or damage. And remember, our nervous system is built to detect danger or damage. In a sensitized, or remember, turned up, the volume knob is turned up nervous system, chemicals released by low moods and associated feelings can turn up the volume even more and make our pain worse. These are what we would call the mood, feelings, and thoughts as DIMs. We nickname these DIMs, the dangers in me, and they can cause or trigger just as much pain as something physical. So for example, the dangers in me, the DIMs, if we were to use the screen here, the illustration on the screen. So the DIMs in this person could be poor sleep. They could be feeling scared and fearful of pain, fearful of moving, and they're feeling quite stressed they're overwhelmed by life. These are the dangers in me. Also, not necessarily to do with thoughts and the brain or cognition, for example. There's also being run down, so having a rundown immune system, avoiding activity and friends, so social life comes into this. So here, this person, because of the DIMs, the dangers in me, the dial is remaining turned up. But it's not all doom and gloom I promise, thankfully, it works the other way too. We can turn the dial back down. The natural chemicals associated with happiness, fun, and satisfaction can act to turn the volume down. This is a powerful system which some people have likened to a medicine cabinet in their brain. By doing things which are enjoyable and meaningful, we can start to harness this. So re-engaging socially, though it can be daunting and hard at times, re-engaging in normal activity for you and movement, getting strong again, exercising, managing our stress instead of it managing us. So these are all things in which can turn down that dial. Now, turning down that dial isn't as easy actually as turning it up. Remember, our brain creates neural pathways. And unfortunately, the brain creates neural pathways way quicker than it does in removing them. And the longer we stay in a neural pathway, or the longer we use that neural pathway, so think of a track going through a forest, a running track. Everybody uses that running track. What does that running track look like to you in your head? Everybody uses this track through the forest. So on either side of the track, there should be grass and whatever growing, but on that track, it's compounded dirt, right? That's what like a neural pathway looks like. Now you need to try and undo that. Okay, you got to leave it alone for a long period of time and it has to overgrow. So it takes a bit of time and effort, but you can turn down that volume dial. Right. Let's now have a look at arthritis and pain. Let's now put arthritis, or should I say the arthritis, the context, the lens now is going to be arthritis, and let's place pain in that. So now you know what pain is, you know how it works, you know the differences between acute and chronic pain. So what about arthritis and pain? What are you feeling when you have pain with your arthritis? Well, people with arthritis can feel both acute pain due to tissue damage and other general disease processes. So for example, this might be, you know, pain in your knee or your back or your hips or your fingers, toes, going from a seated to a standing position. And this, and the cause of that might be lack of synovial fluid. So that fluid between, you know, two joints, or sorry, should I say two bones that form a joint. Lack of or minimal movement of synovial fluid. I remember that helps lubricate our joints, and that's why we might feel a bit stiff when we get up, and that can be interpreted as pain. But that could be that could be acute pain. Or, for example, if you've got a rheumatic autoimmune condition, you could be experiencing a flare-up. And at that point in time, you are suffering some acute pain because tissue damage is occurring when you have a flare-up. So there is an acute pain or tissue damage side to most arthritis conditions, more so your autoimmune rheumatic conditions, less so the osteoarthritis conditions. But many people, as studies have shown, many people with arthritis do experience chronic and persistent pain. So arthritis is likely a mixed pain state. That's not to say that everybody has chronic and persistent pain if you have arthritis, but many do. Interestingly, the most commonly cited peripheral pain mechanism, besides direct input from, say, tissue damage, is peripheral sensitization. So that's saying that the volume knob is often turned up peripherally. So, or where your arthritis might be. Your arthritis might be here in the peripheral nervous system at your knee, or at your hand in your wrist, or in the bones of your spine, for example, okay? That's often where the dial is turned up. So what does that mean? Well, that means that those nerves in that particular area where you have arthritis, any type of arthritis, the dial's turned up, they're hypersensitive. Any movement might trigger messages to the brain. The brain goes, danger, pain. You then might even think of a particular movement or pattern that in the past has caused you pain. Therefore, it's going to hurt more because your body, remember, your brain always wants to protect. So that's really interesting. And it probably plays an important role in chronic pain, of course, mediated by osteoarthritis and rheumatoid arthritis. Not only that, central or changes in the brain also contribute to mechanisms of chronic pain. For example, you may experience other symptoms or conditions that would not necessarily be explained purely by peripheral or tissue problems often seen in that area. So an example being, you might suffer from fatigue. You might suffer from insomnia. You might have arthritis in your shoulder, your elbow, or your knee. Or if you have a rheumatoid arthritis, it might be both knees or both hands. You may then feel other areas of pain. So stiffness in your neck, for example, or pain in your neck, pain in your low back, pain in your ankles. But there may not necessarily be anything wrong, or it commonly isn't affected by arthritis. So that's also very interesting. Once there's central changes, like changes in the brain, often that dial is turned up and we start to feel and we start to get lots of information from lots of different inputs around the body. And we interpret that as pain. So that's quite common. So what else is common when it comes to those, when it comes to suffering from chronic or persistent pain? It's actually comorbid with, or there's a relationship, whether that be bidirectional, with anxiety, with depression or low mood. Now, these may not be clinically met. So it may not be clinical general anxiety or clinical depression, but symptoms of. Sleep disturbances is a big one, often because when we lay down at night, we start to feel that pain come back. And there's a reason for that, but I'm going to discuss that in the sleep webinar later on in the year. People may suffer lowered self-esteem because they feel like they may be losing dependency or independency, anger, lots of confidence, and catastrophizing, ruminating, and kinesiophobia, so fear of movement. So let's have a look then on how we may start to manage our pain. Well, number one way to manage your pain is to learn about pain. So you can check that off your list tonight. That pain education really does help us understand what we're feeling and why and how. So you may now not be so afraid of pain or to come up against it and start to re-engage in your normal movements, because the likelihood is, unless you know it's a flare-up, for those with rheumatic autoimmune, unless you know it's a flare-up, often the case is if you're experiencing long-term pain, it's often chronic pain, and that's not associated with tissue damage. So that sometimes helps people's confidence when it comes to moving more normally again. But what else can we start to do? Start to monitor your pain, and you might like to do this through a pain diary or using a visual analog scale, which is this little instrument down here. So keeping a pain diary allows you to look at triggers of pain. So mood, activity, and sleep are the big ones. Do you have any medication when you took it? And then you can monitor how you felt. And the monitoring can be done through this FAST score here. So, 8 out of 10 of pain, or 2 out of 10 of pain for that day. And you can start to see patterns which can really help inform treatments. I think also regularly reassessing your therapy with your GP or healthcare team. Things might start to change, and you might then need to set new goals or add new treatments. Other ways is to address and change maladaptive cognitive patterns. So catastrophizing and ruminating. So thinking the worst of things and that just blowing out. Constantly thinking about things that you can't do, what's going to happen if. With this, sometimes it's good to keep a little notepad next to us or pen, particularly at night. And you can write down things that are worrying you. And sometimes that takes them off your chest, takes them out of your head. Sometimes you can be proactive and write yourself a to-do list for tomorrow so you can check those things off that are bothering you. Fearful anticipation of pain. This is something that a physiotherapist or exercise physiologist can help you with. So many times I've treated clients who from a standing position can't bend forward. But if I lie them flat and I lift their legs up, or I get them to reach up to their legs in the air, they're bending their spine and they're bending. And I just say, what's the difference between you standing or you lying on your back? They're like, oh, nothing. Really? So even just having small realizations like this can help reduce the fear of or the anticipation of pain during movement. Belief that normal activity should be avoided. So that should have a nice big red cross through it. So this is a belief that you need challenged, that you need to start to work towards moving whatever normal is for you. Back in the earlier on, if you hurt yourself, doctors would tell you this long time ago to lay down and rest and do not move for X amount of time. But we know now that movement is key in majority of rehabilitation and getting people out of pain again. Extreme guarding when you're moving. So if you're that person who potentially has to brace, hold their breath, Balsam maneuver, hold their breath or brace their core, these are the things that we probably want to ease up on. It's not normal to brace like that when you're just getting up from a seated position, for example, or when you're going to bend over. We should be breathing somewhat normally. So these are things that you can address with a physiotherapist or exercise physiologist. Cognitive behavioral therapy and acceptance and commitment therapy have also shown efficacy in improving pain intensity, so reducing it, coping and pain behaviors. CBT and ACT is something that I'll be touching on again later in the year as well. So I'll be looking at CBT, ACT, and sleep as topics of webinars later in the year. So I'll go into a deeper dive of those later. Now, medications always seems to come up, and a majority of these you are going to be aware of. And some of them I haven't touched on because they'll be touched on in our complementary medicines. But analgesics, I'm sure we're all aware of Panadol, Tylenol, osteopanadol. These do help reduce pain but have limited effect on inflammation. For inflammation, you're probably looking at a non-steroidal anti-inflammatory first, like an ibuprofen. This reduces both pain and anti-inflammatory. For topical pain relief, have you tried the cream capsaicin? It actually has some really good evidence behind it, and the Royal Australian College of General Practitioners doesn't recommend many other topical or complementary medicine, therapy, pain relief options, but it does recommend, if you will, capsaicin. Now, I went to do this yesterday, but I just wanted to double check with everybody right now how many mils you might like to get. Let me just look that up right now so I don't forget. If you're interested in trying this, capsaicin patches are actually used for neuropathies in diabetes and potentially shingles sometimes. So you really need to talk to your doctor about capsaicin, like any really high dose or stronger capsaicin medication, patches. pain patches, capsaicin cream. Here we go. Let's have a quick look there. So you can get capsaicin cream like over the counter. You can ask for it like the pharmacy. So it's just to rub on the area and it disrupts the pain signals. So you know how that dial's turned up in the periphery areas, like down in our limbs, in our hands or our fingers, whatever that might be. Applying cream to that area can actually really help reduce the amount of noise or chatter going back up to the brain. It actually disrupts nociceptors, and nociceptors are part of the nervous system, and they're the ones that detect the danger. They're danger sensors. So a 0.75 cream is good. Here we go. If you're interested, of course. Dosing 3 to 4 times a day, rub it in, of course. Okay, I'll find the actual millage in a moment. But that's something that you might like to check out. Those people with rheumatic autoimmune conditions, like obviously taking your particular medications, DMARDs, biologics, they're obviously used to control the immune system. And if you're controlling the immune system, you're reducing the amount of flare-ups, therefore the amount of joint pain and deformation. Corticosteroids like cortisone, this suppresses the immune system and also reduces inflammation, though these aren't to be relied on a whole lot because they can have the opposite effect. They can weaken bone, weaken tissue in the area like cartilage, like ligament and tendons. And there's a link with osteoporosis as well. And then lastly, you've got opioids, narcotics. Codeine, tramadol are weaker variants. Then you've got methadone, you've got fentanyl being the most full-on opioid you can get. Now, these are used to treat moderate to severe pain when patients aren't really responding to all the other pain medications. And they often aren't relied on and really should be used on rare occasions and in very small amounts and only over like a 24, 48 hour, 72 hour period. When it comes to opioids, I always like to just very briefly mention it because there is a little bit of an epidemic or concern about opioid use with overdosing and dependency addictions forming in Australia due to chronic pain. So research shows that they are not effective long-term. Opioids are fantastic for short-term, like a severe acute injury, like surgery. It only provides a 30% reduction in pain. Now, that might seem like a lot when you're in pain every day. But after a short while, you can develop a tolerance to the opioids, meaning that you need to increase the dosage to get the same pain relief. And there's that dopamine is also released, which is part of our reward system. And once that starts to be engaged, we can actually develop an addiction to these. High doses and long-term use of opioids may lead to an increased pain experience, which is odd because they're not supposed to do that. This is actually called a opioid-induced hyperalgesia. So it actually has the inverse effect, or it can have the inverse effect. And of course, if you're wanting to come off opioids, there are hugely unwanted side effects like insomnia, diarrhea, sweats, fevers, etc. So what you want to do when it comes to pharma intervention is look at the 4 Ps. So you want to look at prevention. So you want to make sure we're getting good sleep, good nutrition, psychological. So address negative frames of minds, anxieties, low moods. Get physical again. learn to move well again without fear. And then, of course, there is the implementation of the pharmaceutical side of things. But it's one of 4 ways to address pain. There are more ways. So I've mentioned eating healthy and increasing physical activity, working with our emotions, increasing our social and support networks, improving sleep, obviously trying physical therapies, relaxation, meditation, and distraction therapies. I'm going to include that in the CBT webinar later in the year. Quitting smoking, pacing and saving energy. So breaking up larger tasks and putting them into, or breaking them into chunks, okay, and doing them over a longer period of time. So the key messages here tonight that I want you to take away is that pain is complex and we still don't fully understand it. Pain doesn't always equal harm. So that hopefully helps you when it comes to managing your pain. Is this acute pain or is this chronic pain? Consider your DIMS, the dangers in you, the things like mood, the things like anxiety and stress, the things like sleep, the things like the negative or those sort of cognitive patterns that might be pulling you down instead of pulling you up. Challenge and change your negative thoughts. So try meditation, mindfulness, CBT, distraction. Ensure you take your medications as prescribed. Exercise as best you can, when you can, and as well as you can. Socialize and increase a sense of community and connectedness. So we're really looking at that whole of life approach when it comes to managing pain. Okay, that brings us to tonight. So what I'm going to do is I'll just stop my share and I'll bring it back. Okay. So thank you all so much for coming and participating in the polls. I hope you have learned something new today, something that will hopefully have helped you today or tonight. If you have any questions, I'll do my best to answer them. You can write them in the chat box if you like, or if you want to come off your mic, you can ask me a quick question. That's up to you. If you need to go right now, not a problem. See you later. Please look out for the feedback survey coming your way. Feedback is really valuable to us and it informs changes that we may need to or want to make to our presentations going forward. Obviously, this was a good time for a lot of you tonight, so I like doing the evening ones. It captures a different audience and allows people to come along if they're working and busy during the day. What does DIM stand for? Good one. I'll write it down in here. Dangers in me. So when we might hurt ourselves or our dial is turned up at a site of an injury, this is peripheral. When it comes from our brain, that's central. And so the dangers in me can actually trigger us to feel and experience more pain. So that could be thoughts, mood, feelings. Hope that made sense. Paula, are muscle relaxers an alternative to painkillers, or do they serve as a different purpose? That's a good question. I'm actually not sure if they do serve as a painkiller. Have a quick look what their ingredients are, but muscle relaxants, muscle relaxants might be used for people who have conditions where there could be having like a lot of cramps, for example, and other neuromuscular conditions. Let's have a quick look. I'll see if I can find it. What is it? Muscle Look, I'm having a little look here what might be in them. Look, they may actually ease or help to ease pain. I mean, there is the effect that let's talk about cramps, for example. You know, when you get a cramp, that's extremely painful for many reasons, but it's painful because the muscle itself is stuck in a contracted position and it's lacking oxygen, and that builds up a lot of noxious chemicals that irritate the nervous system and cause a lot of pain. So if the muscle then is relaxed, then it doesn't have that excess contracting. It's getting oxygen and it doesn't have the noxious chemicals building up. So in that side of things, it can ease pain, but I would certainly ask a pharmacist or your GP. Trigger. Tiger balm. I love. People can absolutely hate Tiger balm. Some people love Tiger balm. Yes, it creates a sense of heat. Do you know when you when you hit your funny bone? It's not particularly funny, is it? It actually hurts. Or when you stub your toe or you do something like that. What's one of the things that you do unconsciously to help it? Well, I rub it. I rub, right? So what Tiger balm does, or other creams such as our physio cream. Physio cream is similar. It creates heat and has a nicer smell. It has more natural ingredients than some like Voltaren, for example. What heat does is it acts as a distraction, like me rubbing where I've hurt myself. When you add a competing stimulus to pain, the competing stimulus wins the race to the brain. Does that make sense? So when you add heat cream, when you add cold, when you add a friction or rubbing or touching or massage, that can actually help dull the sensation of pain because it beats the messages to the brain than pain. So that's really interesting. What's the idea behind magnesium stopping pain or cramps? Yeah, that's a good question. We need magnesium to help muscle contraction. But really either drinking it, like ingesting it, or rubbing it on our skin, it actually doesn't happen instantaneously. If you ingest magnesium, like in hot chocolate or something like this, or some other formula or tablet, it actually needs to go into your stomach, into your small intestine, and then is released. Or if you rub it in, it can take a long time. Maybe it doesn't even reach the muscle, I'm not sure, through the skin. But that's the idea. There is the magnesium helps muscle contraction, and so the theory being that maybe it's lacking magnesium, and so creams, tablets, drinks, they go, here, take some more magnesium, that might help. Any other questions? Yesterday somebody brought up like the use of cannabis or cannabis oil. I've written about that in an Ask Cat blog, which you can find on the website, but I might touch on that in the complementary medicines webinar later. Yeah, that might be Michelle, that might be the case with the Epsom salts baths. I'm reaching here as to my explanations for that, so I might leave that. Trudy says physio cream is awesome and can be used after a bath or shower without burning you like Denka Rub does. Yeah, that's right. Physio cream is awesome, and it is spelt that way. I didn't spell it wrong. It is spelt with an F, and you can get it from like a discount chemist. What is it? Chemist Warehouse, things like that. Have a look around for stock lists. All right, guys. Yeah, look, if there are any other questions, ask them now. If not, thank you so much for coming, and have a great evening, and perhaps see you all in future webinars. Thank you, everybody. Good night. Good night, Faye. Good night, Cecilia, John.
Good night.
Good night. You're all leaving so fast, I can't say your names, but it was lovely.
Good night.
Good night.
Goodbye.
Thank you very much.
Bye. Joan, is that a question, a high five, or a not sure?
It's a thank you. Thank you very much. Thank you.
Yes, I should have said happy Easter, everybody. Totally forgot about that. Whoops. Happy Easter all who are still left on the webinar.
Thank you.
Good night. All right, I'm gonna end now. Good night.